Care Access Delivery and Payment Task Force Workforce Workgroup. I'm David Seltz. I am the Executive Director at the Health Policy Commission and co-chair of the task force, and really pleased to convene this meeting today, to have all of the members of this work group here to continue these important conversations. As I acknowledged at the last full primary care task force meeting, the co-chair for the task force, Dr. Kiami Mahanya, has elected to designate Dr. Ryan Schwartz as the new co-chair for this specific work group. Secretary Mahanya, as we're all aware, has been promoted into that important role. I think is actually being sworn in by the governor today. And so I know a few of our members here are bouncing back and forth between that event and this event, and we congratulate him and wish him well. But it's great to see everyone here today, but to kick off the meeting, I'm glad to turn it over to Ryan.
Thanks so much, David, and thanks everybody for joining us. And for those of you joining remotely, thanks for joining us today. I'm really excited to be working more with all of you and helping to lead this work group moving forward. We have a big mandate in front of us and a really, really important one for the Commonwealth, and most importantly for the patients that each of us serves every day to deliver. So a lot to do. Earlier this week, we shared with members of the work group a list of potential priorities for us as a work group to really focus on as a part of this workforce work group over the coming 6 to 9 months. And we see that list as a draft list that we really want to dive into today. So that'll be the first half of the meeting. A lot of great ideas were surfaced in our previous work group meeting, and we'll kind of resurface those and use this as an opportunity to align on a list of topics that we really want to prioritize moving forward. The second half of the meeting, we're going to focus on the final deliverable for the broader primary care task force, which is a deliverable around creating the short-term and long-term workforce development plans for supply and distribution of primary care clinicians and other primary care workers. So that'll be the latter half of our meeting. Before we do that, though, our first order of business today is to approve the minutes from the June 10th Workforce Workgroup meeting. So since we are doing this meeting remotely, we will go through a roll call and we'll ask each member of the task force to vote yay or nay on the meeting minutes. So with that, we will move over to the minutes. Before we take a vote, does anyone have any comments, questions, amendments, or revisions they'd like to suggest as a part of the minutes? Okay. Seeing none, I will entertain a motion to proceed with a vote.
So moved.
Second.
Second. Thank you very much. Colleen, can I turn over to you to go through the roll call?
Absolutely. I'm happy to do so. I will start with you, Dr. Schwartz.
Yay.
David Seltz.
Aye.
Dr. Pring.
Aye.
Dr. Black.
Here.
Allison Bracken.
Here.
Dr. Critchlow. Thank you. Dr. Gilchrist.
Yay.
Dr. Martin.
Yay.
Christina Severin.
Yay.
Thank you. And I don't see Dr. Spivak. So that is the vote. Back to you.
Thank you so much.
I have a quick question on that.
Sure. Go ahead.
In the primary care task force full meeting, when they were doing the roll call and the minutes vote at the same time, a couple of people said present, which is not actually I.
Yeah.
And I'm not sure if they're recorded as present or as voting in favor. So I spent too much time in Robert's Rules of Order when I was a little kid. It's an addiction. I apologize. But if people vote present or here, is that counted as an I?
Yes, we're assuming people, it's just a minutes vote. It's not a vote on attendance. So we're just assuming people are voting for the minutes. If anyone wants to vote off or abstain, they would need to be clear on that. But we take a casual stance. But thank you for the clarification.
Great. Any other questions or comments before we move on?
I also vote aye.
Thanks, Wayne. All right. So we'll start our discussion off with reviewing the priorities that we circulated. So members of the work group should have received a list earlier this week of the priorities that you had discussed during the previous work group meeting. Before we dive into that, I do want to refresh for each of us kind of the three top priorities, high level, that this workforce work group really needs to focus on. And then we'll dive into some of the discussion topics as well. So the first priority for this workforce work group is to develop an approach to short-term and long-term workforce development plans to increase the supply and distribution of the primary care workforce. The second is to develop recommendations on advancing patient-centered team-based primary care. And the third is to develop recommendations to improve working conditions of primary care clinicians and other primary care workers every day. So some fairly aspirational goals. And as we circulated to the group, we tried to bucket out a number of the topics that this group raised for potential discussion and work as a part of the work group. So we'll quickly tick through some of those, and then I would love to open it up to this group for feedback on this list. Does this seem like the right list, and are there anything that we should be changing or adding to the list as we think ahead about the agenda and the subsequent discussions that this workforce work group will take on this year? So big bucket number one under working conditions, we've talked a lot about admin burden and prior auths, referrals and credentialing, network and formularies, different approaches to staffing support, and quality measures and pay for performance and ways to potentially streamline that. Bucket number two, we have workforce development and pipeline support. A lot in here, ranging from loan repayment and workforce diversity to thinking about both ways to retain workforce in the primary care space, as well as incentives and ways to build the pipeline and bring new students and or graduates into primary care. A specific emphasis on thinking about how these dynamics and challenges manifest in the community health center space and what we as a Commonwealth should be thinking about. Medicaid GME, always a perennial topic in our state. Nursing and family medicine residency training programs. And then a third bucket here on care delivery models and scope, thinking more critically around behavioral health integration and team-based primary care, the growing and evolving field of direct primary care, telehealth, and continuous practice for PAs. So that was the list that we circulated, and we will pause and open it up to this group. We would welcome feedback on this list.
Ryan, this is Christine. I apologize for not raising my hand.
It's all good.
And
go ahead.
For being off camera. I am en route to Secretary Mahania's swearing in. This is not the most material comment, but I noticed in what you sent and in this slide that far left working conditions, first bullet, administrative burden. All items that follow that first bullet are items of administrative burden. So I'm just curious, like, should we strike through addressing admin burden or have working conditions be subbed out for addressing admin burden or addressing working conditions and administrative burden? But it feels like the rest of that list is detailed items around administrative burden, and that therefore that first bullet isn't really concordant with the rest of the list.
Thanks, Christina. Fair comment, and I think yeah, we will certainly think about how we can best synthesize this list. But I think the overall theme here, as you're calling out, is that admin burden is definitely a priority for this group. David, anything to add?
I completely agree. I think addressing administrative burden is like a broad bucket term. I guess I would wonder if there are things about improving the working conditions that aren't necessarily about reducing administrative burden that we might want to still entertain. And so I think maybe Christina, keeping the broad topic of working conditions and then recognizing that a lot of these are going to be on administrative burden. We can just kind of frame that a little bit differently.
We'll just go in the order that we see hands. Apologies if I missed the order here. Renee, I believe you were next.
Yeah, thank you. What I would say is when we're looking at the pipeline support, I do think it's important for us to explicitly point out prior to students graduate, because we're talking about new graduates entering primary care. We need to have a discussion on the frameworks of the medical schools and why they are producing people who don't go into primary care. So I think a commentary on the pipeline extending into medical school and probably earlier even, but the idea that if we wait until they've gotten through medical school to try to convince person that primary care is a worthwhile field, then we've continued to perpetuate the situation that we're in. So understanding that medical schools have a big impact on framing the physician workforce, and we need to have at least a comment on what's going on there.
Thanks, Renee. Totally agree, and probably earlier, including STEM programs. So yeah, thank you for the feedback, Barbara.
Thank you. I think there are other things that go under I have two comments. One is that I think there are other things that go under administrative burden that affect the lives of and the work-life balance that push people away from primary care. And those are more difficult to address. It's the, quote, inbox management around electronic health records. It's the requirements around coding appropriately so you get the right risk code. So I think leaving administrative burden up there, there are other things that we do need to address, and that will often require changes in payment reform to address, as well as staffing support. But I also think that we need to highlight, when you talk about incentives for new graduates to enter primary care, many of those incentives right now focus on and spotlight community health centers, which is very important. But when I look at and talk to people who live in communities in Boston, surrounding communities, the western part of the state, there are often not federally funded community health centers that are near them, and yet they have trouble getting into primary care practices. And I think one of the things that we really need to think about is how do we expand support for both private practices that are in primary care, as well as employed private practices, like not federally funded health centers, but are employed by an academic system or a for-profit system, so that we expand those supports in a very dramatic way for people to want to enter primary care. And there are ways of doing that that will not detract from pushing and encouraging people to go to the community health centers either. Thank you.
Thanks, Barbara. Brenda?
Thank you. As a pediatrician here, I wanted to just add, and I think my colleagues who take care of adults would also probably agree, but other measures to address provider burnout, that last bullet is a pretty significant one. And, Dr. Spivak sort of spoke to some of the things that I think aren't necessarily administrative burden, but are part of more of the burden of providing primary care these days. And maybe at a pediatric perspective, we're hearing from a lot of parents, but, there are a lot of portal messages. And the answer isn't just more staff necessarily, because these are things that we want to sort of take care of our patients as PCPs and be able to manage their inquiries, but it's not sustainable when we're doing all the other things, as well as trying to see the patients just to, help the numbers and also see the patients and manage them. So I would add that second point, and I mentioned this at the last meeting, but I do think, at least in pediatrics, we are doing a lot of behavioral health, and some of that is because the needs have changed, but a lot of that is because there's not enough behavioral health support. So we're doing extra training so that we can do the things that we were not trained to do in residency, and doing mini fellowships to take care of sort of straightforward depression and maybe slightly more complicated depression, things that maybe one could argue are for PCPs, but at the same time, our models don't allow us to spend the kind of really needed 20, 30, 40 minutes to assess and manage and follow up on medications and treatment plans. And also then there's no one to turn them over to, which is different. I love the part about having sort of integrated behavioral health, but that's a little bit different. That's a lot of therapy often or other things, but as a prescribers, there really are not sufficient amount, at least in pediatrics. And just the third point I wanted to make is that the Mass chapter of the AAP, we are working on a system, trying to work on getting more of our trainees, so slightly different from Dr. Critchlow's point, but the trainees to maybe be more exposed to primary care in their pediatric residency. So they want to take care of kids. They spend 3 years learning all about about hospital medicine. And we have a grant, the Healthy People 2030 grant, to work on changing that in our state. Thank you.
Thanks very much, Brenda. Stephen?
Hi, thank you very much, and I really appreciate the comments already and the work for this agenda and discussion topics. I'm just looking at working conditions and care delivery models, and we'll put in the chat 2 recent New England Journal articles that are very germane, because we're doing work that we hope will extend and know for years for the Commonwealth and be durable. And yet the headwinds we face are substantial. The 2 articles are titled "One, Primary Care from Common Good to Free Market Commodity." And the other more recent one is "Defining Healthcare Corporatization." And if we do not acknowledge that the healthcare system as a whole is in the framework of a profit-driven model, we're not going to do very well with primary care, because primary care really isn't built to create profit when it's done best for patients. So I'll put those in. They're very thoughtful. They include 2 interviews. Both the researchers are from Massachusetts, and they have a lot to offer us. Specifically, just quickly on working conditions, I would say, and other colleagues may certainly agree, I'm in an academic-based rural health center where many of my patients have tremendous social needs, are homeless or virtually homeless, are hungry, and I do not have staffing. I do not have a social worker. I don't have anyone on my quote healthcare team that can directly help them. And this is a real absence for their care. And I'm a poor substitute for people who know how to do it better than myself. And I don't think when we say adequate staffing support, I think adequate staffing support for what? And this gets right at our core principle of extending equity in the work of the task force. And this is highly inequitable currently. What is also inequitable is the performance quality measures. Myself and others have researched this carefully. The current pay for performance measures move money from people who need care to people who are relatively healthy, because they measure things that are numerable and available and transparent, which is something like blood pressure. They don't measure whether someone's not suffering as much or can breathe better. And so I would be cautious and would not want to use the wording here of streamlining reporting. We have to take an absolutely fresh look at pay for performance at all. Pay for performance actually does not lead to higher quality. This has been proven over and over again. And so I'd ask that we please be cautious and not use the current framing as listed here. Thank you.
Thanks, Stephen. Appreciate it. Laura?
Hi, just a couple things. Just although there is NPs upon graduating do tend to go into primary care, and I think this is something that as president of MCMP, we need to make sure we're getting this data, is understand how long, how often NPs are transitioning out of primary care, moving into specialty care. We're finding that more and more, again, because of the administrative burden and the burnout related to primary care. So that's a piece of data we should get. Also, I am going to put like Mass Health on the spot here. I mean, as far as administrative burden, we're already seeing that we are re-implementing the process where primary care needs to get the approval for our patients to see a specialist and go through that process. I know we're getting retrained on that very soon, and I kind of find that to be interesting and a little ironic during the course of this whole conversation that we're talking about these specific and very important topics, and meanwhile we're going to be faced with a very real challenge of having to restart that whole process over again. And I know in my practice we have very little administrative support, so we're going to be spending a lot more time working on that as well. And then I want to go back and talk about that inbox situation. It's true. We get so many inquiries, questions, conversations that we need to have with our patients and their families. And we do want to do that ourselves as providers because we do want to be able to make sure that their care is well coordinated. And that's really critical to make sure we've got good outcomes for our patients. Thank you.
Thanks, Laura. I appreciate it. And I think there's a separate conversation to have about the MassHealth specific requirements here. And I know we've discussed separately. For others, MassHealth is re-implementing after a 5-year pause due to the COVID-19 pandemic. Some referral requirements. I don't know that that's necessarily, this is the venue for that discussion, but happy to follow up and discuss that in greater detail. David?
So I agree with a lot of my colleagues' comments already, so I'll try not to duplicate any of those. 2, in the workforce development and pipeline support. 1, for patients who live in more rural areas, as Steve has mentioned too, I think that's an important thing to think about. What is the rural track training pipeline to make sure we meet all the needs of our communities? I also think about return to practice. Think about clinicians, especially probably more physicians just because of the workforce in terms of the age, that have recently stepped out of practice because of the challenges and the burden. And it's an untapped, really skilled group of clinicians that if there was a pathway to keep them engaged with less of the burden, they might actually continue to provide care. So thinking about innovative approaches to our later career physicians and clinicians. Under the care delivery model and scope, I don't see, and it probably is out of scope for the workforce work group, but again, value-based payment, prospective payments, kind of payment models needs to be part of the discussion in this category. And then lastly, and this may be going a little bit out there, is to really think about a more public health approach. What are the elements that we've baked into our office-based visits that actually should be pulled out into a more public health approach? So we start to fundamentally ask, what is it that we should be doing through public health and not tying it to a visit with a clinician? And that's a really big conversation, I think, because that is a fundamental change in the way we provide care as a state.
Yeah, thank you, David. On the payment models, David Seltz, I'll just call on you briefly, but I believe we're addressing that separately in other aspects of the primary care task force. Is that correct?
I think the thinking is that will be a conversation that we will have with the full task force. There may be elements that kind of will come back to this work group on to kind of think through the intersection. But I think, David, to your point, they're tied together, right? Like, what do we want the care team to look like? And then how do we pay for that and support it? So I agree that they're conceptually linked. Christina?
Thank you. Maybe related to that last comment, and if it's elsewhere, that's totally cool. On the care team, I think we need to take a hard look at what have historic roles and responsibilities been on a care team, particularly between licensed and unlicensed professionals, to right size sort of what is real clinical need, what perceived clinical need can be appropriately and effectively managed by a trained professional who is not a clinically licensed professional, assisted by other items like AI, for example, and team-based care, so that we can maximize the appropriate use of licensed professionals and not overly depend on licensed professionals to do work that doesn't require a clinical license. It's a complicated thing, but that is how I would describe the headline of that thing. I shared with Dr. Steve Martin, we studied this a few years ago in clinic, and we found that about 50% of primary care visits, that could be MD, PA, or NP, the perception of that licensed caregiver was that the visit did not require a clinically licensed professional. That was 50% of visits. So I think there's an opportunity there.
Wow.
Yeah, thanks, Christina. I will say that 50% resonates personally. So I'm sure other folks on the call would probably agree. Acknowledging we're coming up on time, we'd like to transition to the next part of our conversation. So I'll take Wayne's comment and maybe one more, and then I think we're going to move along. Wayne?
Hi, thank you. So I'll be brief, Ryan. A lot of what we talk about in this category is how to make the clinician experience better, having better teams and not burning out as much and so on. I think it's really important to remember that a huge part of this effort is about delivering a better experience and a better quality product within primary care for our patients, especially those patients who are most vulnerable.
Thanks so much, Wayne. Agreed. Christina, did you still have another comment, or is your hand still up because you're in transit?
Sorry, took it down.
All good.
Ryan, but before we move on, can I ask a question of the group here? So first of all, great discussion, and I think you've given us a lot of feedback of things to add to this document and to this list, and by no means exhaustive, but thinking about the portal messages, interactions with EHRs, coding, thinking about what the behavioral health needs of different patient populations are and how those can best be addressed, whether that's through integration or is there additional training and supports that are needed, thinking about the medical school structure, kind of throughout, not just entering, but throughout the course of medical school. Stephen Martin, you talked about, and I think this can fit kind of maybe in the care delivery models around how do we have the right types of supports to address the social needs, health-related social needs of patients, and what does that look like? Is that a social worker? Is that a CHW that we're thinking about as part of that? On the workforce development, retaining NPs in the field, return to practice for different providers, a rural track training, and Christina and others at the end here, in talking about care delivery teams, can we have a conversation around what are the roles that are part of that team, and are there best practices or ways that we want to kind of describe the relationship and that, perhaps best working relationships between clinical and non-clinical staff as part of that. So that's by no means exhaustive of everything that you just said. We have got people taking very copious notes, so we'll put all this in. And so thank you for all of that. I guess my question before we move on to the next topic, and I think we're going to try to start the conversation on workforce development and pipeline support today, by no means expecting that we're going to tackle any of these in full depth, but really to just kind of start that conversation. What would this work group say are the priorities? Like, where should we start if we had to pick one of these buckets and to focus in on? And are there additional people or research or resources that we want to bring to the table to help us on some of these conversations? So an open question to the group around prioritization and what additional information we'll need to make progress.
Renee?
I have no problem with the idea of prioritization or triage, but it's going to be very important to understand that none of these can be left out. Zero. Because it's about pipeline, practice redesign, and payment reform. That three-legged stool is going to be critical. Now, when we talk about, when we look at practice redesign, that addresses the working conditions, but it also addresses pipeline. We need to be training people in those places. And part of what we need to be addressing with the pipeline is also practice redesign, because if you train in a place that has team-based care, where you have joyful practitioners, it's more likely that you'll contribute to that as your experience. So I do think it's fine for us to think about prioritization, but the bottom line is nothing gets left behind. All of these things need to happen. The biggest thing that is beyond our scope is the payment reform, because that's going to allow the subsequent things. The other parts are, with the pipeline, we have to think short-term and long-term. Short-term, the pipeline is addressed by the working conditions. Creating a way for practices to remove administrative burden means team-based care that has to be paid for. However you develop it and design it, fine. But working conditions are the bottom line, and they have to be addressed by payment. How we encourage people to go into the pipeline, really, that whole thing centers on working conditions. That is the pillar. But if we don't start right now with changing some of the approaches we have to primary care as providers, like I'm going to continue to hit on the two largest health systems in the state don't have family medicine residencies. And, the data that I've seen around NPs, I'm glad Laura brought that up. One of the biggest things that happens with nurse practitioners, 75% start in primary care. National level, it looks like only 47% stay in, anywhere from 25 to 47%. That means that if you're looking for someone that stays in primary care, that is a family medicine physician. And I know I'm biased, but I'm biased for a reason. I entered this profession because it is the place where you get to take care of kids and adults for the whole cycle. And that's the thing, over 90% of family medicine folks stay in family medicine. You talk about rural, you talk about maternity deserts, you talk about access issues. Every single one of those are addressed by family medicine residencies and family medicine physicians. So God bless all my colleagues. I adore you all. But if we don't make a commitment to deeply pushing family medicine physician training in the state of Massachusetts, we will not be able to fix primary care. I won't say anything else. Thanks, guys.
Thanks, Renee. Laura, I think you were next. Laura, you're unmuted.
Sorry. It would be worthwhile instead of to do some sort of a process where we could understand what's impactable, what's reasonable, what's doable. And as we're going through a process of plotting out prioritization, because some of this is going to be completely out of our hands regarding legislation, but other things could be done around the edges inside of institutions themselves. So working through different processes by way of, say, administrative burden, taking advantage of some other ways to be reimbursed for activities that we may not have figured out how to get reimbursed for. Now, complex care management, care coordination is a good example. So as far as really being able to determine what of these things should we be tackling first, I agree with Renee, they all need to be tackled, but at the same time, I think we should be realistic about what's feasible and what can be done in a timely manner.
Thanks, Laura. That makes a lot of sense. Appreciate it. Stephen?
If I could go after Allison, because she hasn't had a chance. Thank you.
Sorry. Thank you. Go ahead, Allison.
Oh, thanks, Stephen. I was going to pretty much reiterate what Laura said too, and I do agree that all of these should be tackled. I do feel like the workforce is trying to figure out like what is doable, and the workforce like incentivizing either new graduates or like as far as PAs go, we don't we have a very broad education, and so kind of I think even if you did start at the level of education, you could add in more primary care rotations and things like that. But as soon as people graduate, they typically, at least for us, out of it when they realize how overwhelming it can be. And so I think incentivizing to keep people in, whether it's loan repayment, if they stay for a certain amount of time. I know that may ultimately let them leave after X number of years. But I think there's a lot of things with the workforce that certainly around the education that would probably be something that could be fixed or kind of worked on in a more immediate way, would be my thoughts.
Thanks, Allison. Appreciate it. Totally agree. Stephen.
Hi, thanks again. Thanks, Allison. That was great. So I'm grateful looking at the slide and thinking of the work of the workforce, and yet, please forgive me, but it does seem in dialectic with the definition of primary care. That is, what is this a workforce for? And I appreciate the great work that we all did last week looking at the definition of primary care and the preparation for that. But it does strike me that that definition is mostly from a billing perspective, which is needed, but there have been decades of research on primary care that have established its benefits, and the benefits are contingent and require 4 different elements. And so I would just have the folks here as part of the work group consider whether adding a short sentence to our recommended definition would be worthwhile. And because otherwise we don't know what this workforce is supposed to do. And this comes directly from decades of literature, that the task force recommendations for the definition of primary care come with the understanding that primary care must be patient-centered and include all 4 of its core pillars: first contact care, continuity of care, comprehensive care, and coordination of care. These are also known as the Starfield principles, period. But that would help frame any definition we have and also allow us in the work group, workforce work group, to know what workforce are we creating or fostering or cultivating. And so without this sentence, I think that our definition has the merits of being measurable, but not the merits of actually describing the work of primary care. So I hope that might be a consideration that we could have. Thank you.
Thanks, Stephen. Agree. David?
Thank you. So I think some of the question is, what from this list do we need to discuss? I think everyone said all these things are important, but what do we as a group need to discuss is probably the way that we prioritize some of this work. For example, like insurance credentialing should come off, just be put at the bottom of the list, and it should just happen. Like someone should be working on that, right? And I think people are. Formulary stuff, like, yes, someone should be working on that. I honestly think I think that's going to be a technology fix. I don't think we're going to figure out a way to actually fix that with one form or something like that. It is going to be technology that can sort through charts and get answers to answer the questions to make sure it's an approved drug. So I think the questions that I think are important are, what should the job be? And so that's to Steve's point. I totally support utilizing that framework as what the workforce is that we're developing. And then how do we pay to get it done? Because that is the place where, again, if we're going to redefine some of what the workforce is doing and how we get it done, then I think that's the place where this group of experts really can weigh in and make a fundamental change. If we're just nipping at the edges, I just don't think we're going to make the impact that we think we're going to make.
Thanks, David. Wayne, go ahead.
Hi, thank you. So I agree with everyone's comment that what do we need to talk about? All of this stuff. And it's a little daunting. It's a lot. And at the same time, we have 3 primary care bills that every single one of them features a list of what we call the transformers. This is a list that really a bunch of folks on this team and other teams have brainstormed for the last 6.5 years, and basically have put a scheme together of how exactly to address most of what we want to talk about. And so it may make sense from a process point of view to start by reviewing what is in all 3 bills, which in this context is basically the same for all 3 bills.
Thanks, Wayne. And I know that we've discussed those pieces of legislation elsewhere, and we'll certainly continue to revisit them. I appreciate folks' comments on the importance of all of these. I think I will also just echo David's earlier question of, we are also trying to use your time in the most impactful way possible and make sure that we are as a group, using the time we have together in a way that will ultimately lead to an efficient set of recommendations. To Wayne's point, this is a fairly daunting and significant list of problems to solve. I don't think any of us are under the impression that we will, quote unquote, solve these problems as a work group. And we do also want to make sure we are using this work group to be as impactful and insightful to our partners throughout the Commonwealth as possible. And the recommendations from this work group should hopefully represent what we think is our best attempt. So it is not an effort to eliminate items, more an effort to ensure that we are using our time as wisely and efficiently as possible. Barbara, go ahead.
I think as we listen to all of this, I think one of the big next steps is going to end up being payment reform. We've had a lot, there are a lot of pieces that are not related to payment reform. I think Renee, highlighted education and training and starting in medical school and with training as one facet of the three-legged stool. But I also think that many of these things are going to require dramatic payment reform for us to really have the impact that we want. And, I think we've talked about this before. It may require some kind of a glide path to change, but I do think we need to add payment reform as a very specific fourth column. Thank you.
Great, thanks, Barbara. Before we move on, David, any other comments?
No, I just a note of gratitude again. I think one of the things that perhaps we can do, coming out of this meeting, is taking this list and lining up next to it, like, what is the lever for change? Is it legislation? Is it, as Barbara, you just said, changing the payment model? Are these things that are within the control of organizations to do on their own? And then maybe a column that's like, and is this going to be impactful? Like, high, medium, low. And then also, to Wayne's point, like, what is currently in some of the legislation, and just maybe putting some of those variables next to each of these items could help us say, okay, where are the areas where we have an identified lever, we do think it'll be a big impact, and the collective wisdom of this group is going to be really important to getting it done. So I would propose that as maybe just kind of an offline next step, and bring that back to this group.
Great, thanks, David. I'll move us along to our next item on the agenda. So we want to spend most of the rest of this meeting, call it 40 minutes or so, discussing the final deliverable for the primary care task force writ large, which is to create short-term and long-term workforce development plans to increase the supply and distribution and improving the working conditions of primary care clinicians and other primary care workers. This is, as we've said already, quite a large bucket. We do have some targeted questions, and today I think we'll probably focus mostly on some of our areas around the pipeline. However, before we do that, I wanted to ask Stephen, if I could turn it over to you, or walk through some data around residency training programs, specifically on family medicine residencies in the Commonwealth. Stephen?
Sure. Thank you very much. And this is thanks to a lot of short-term, quick efforts from colleagues around the Commonwealth to help put this list together that's sort of updated and takes advantage of data that we do have from 2017 in comparison. So thank you. I think this is, I was going to say, a picture worth 1,000 words. It's like a table or chart worth 1,000 words. And if the task force was able to hold and be with this data in a deep way, I think we would start to develop the legs for the stool that Dr. Critchlow described. And in preface, a lot of smart thinking has gone toward the idea of cultivating primary care over the last quarter century. My wife, Ruth, was in the first charter class of the BU Family Medicine residency. That was just in 2009. I'm sorry, 1999, my gosh. And I was in the third year, 2002. So we've seen over the past 30 years, the efforts in the Commonwealth to cultivate primary care. This should humble us because the absolute number of people going into primary care from state medical schools is lower in absolute terms than it was in 2017. And the number of seats have gone up 13%. So we've had, according to my rough calculations here, a 43% decrease in the number of graduates going into family medicine, though there's been a 13% increase in graduates over the past decade in the Commonwealth. And I entered medical school almost 30 years ago. I'm a medical school faculty member. I've been inspired by medical school colleagues and teachers, students. The current graduating rate here, exemplified in the last row, represents to me a broken social compact between the Commonwealth and its medical schools. And this wouldn't matter if everybody just exited the state after graduating from medical school, but they don't. Medical school training is very sticky, and where you tend to train is where you tend to practice. And I'm a big tent person with my nurse colleagues and physician assistant associate colleagues who are stellar and some of my favorite people. So this is a proxy, but the proxy is, as Dr. Critchlow pointed out, this is an important proxy. What is happening to family medicine in the Commonwealth is actually a degradation of something that wasn't great in the first place. And what we do with that knowledge, despite the efforts that have happened over the past decade, let's say, why have things come out the way that they have? Unless we have a thoughtful analysis of why things look the way they do now, we're going to put together two legs on a stool, and I'm afraid that it's just going to not stand. So thanks for time looking at this data and considering it, and I think it tells us some hard news. So thank you.
Thanks, Stephen. Really appreciate it. And I will say, personally reflecting on my own journey into primary care, as many of the folks around this room probably experienced in med school, our own med schools told us not to go into primary care. And I think that is demonstrative of the broken social compact, Stephen, that you're referring to, but more generally a structural problem in the system that if we don't address, we won't be able to make progress on any of the broader goals that we have. Thanks for sharing this. This is very helpful and humbling. So if we can move on to the next slide, want to spend the rest of our work group today really hearing from work group members on what we feel are the priority challenges in the workforce pipeline. We probably have a few too many questions on this slide to be able to get through all of them today, which don't worry, we'll bring them back in future discussions. But if we could start off really talking mostly about the workforce pipeline challenges, and I think Stephen's prelude here laid an excellent foundation for some of that, although I will also highlight again, that was a physician-specific data set, and certainly not criticizing Stephen, but absolutely, we see this as a broader tent and the importance of considering both PAs and NPs as a part of these broader discussions, as well as all of the other team members that go into the primary care team, which is not just the providers, but the many staff that help the providers ultimately serve our patients. So I'll pause and would love to open it up to this group. We have probably about 35 minutes or so. You aren't relegated to stick to the top questions, but we'll focus there primarily, and feel free to also comment on some of the others if you'd like. Laura, please.
Hi, I think probably the first place that I would like to say is that primary care is much bigger than medicine and the practice of medicine in and of itself, right? Steve had mentioned those 4 C's: comprehensiveness, being able to meet all of our patients' needs across a continuum, social needs, behavioral needs, as well as their physical needs. We need to be able to be the first point of contact for our patients so that they don't go to the emergency room. But that doesn't necessarily mean they have to get in touch with a provider per se. It could be a question of having a conversation with somebody on the team to do some type of coordination or quickly get a patient the services that they need. We talk about continuity and having that provider available to be that person to walk with the patient on their journey. And it doesn't just have to be the provider. other people on that team, walking and having these longstanding relationships with our patients as well. And again, coming back to that third C of coordination, I think many of us find that so much of the issues that we deal with our patients and the problem solving and the blocking and the tackling has a lot more to do with coordination and helping a patient get from point A to point B rather than writing them a new prescription for their diabetes. So I just wanted to point that out, how primary care is such a big, broad thing, and we do have a lot of opportunity to improve this for our patients in the state.
Yeah, Laura, I think, it's great to write a GLP-1 for diabetes, but if the patient doesn't have access to healthy food, then it doesn't really make much of a difference. Brenda, please.
I just want to state the obvious, which is primary care is really hard. We're all at the table because we know it's hard, but it's so fulfilling. And I don't know how that gets through to people, right? Every day I'm energized I'm with patients, I'm with families. I have a story every single day when I'm finished of something that really was amazing. And I don't know, I mean, putting a facelift or PR campaign on primary care isn't what it is, but I don't know how to sort of translate that to sort of a fundamental reason for why we do this. And I think that's important and missing from the conversation. That said, we need to be paid better. We need to work less hard. I don't need my kids to look at me and say, oh gosh, I never want to go into medicine because that's way too much work, right? That's the terrible part. They don't see all the joy. And so that's all I have to say.
Brenda, PR campaign might be helpful. We should consider it. Renee, please.
Okay, I tried really hard not to say anything, but then you kept saying things that I know I have the answer to. Like number one, Laura talks about, yeah, we need to understand PAs and NPs are a very important part of it. The PA and NP issue is different. The PA and NP issue about remaining in primary care, they come out of school going directly into primary care. Their solutions are reducing the burden and paying them more. That's straight up. Reduce the burden, pay them more, give them loan repayment, whatever. But reducing the burden is the only way they'll stay. Pay them more is the only way they'll stay. PAs and NPs already go into primary care. But if you don't fix the other two parts, they're not going to stay. The difference with physicians is the people, when you say, I don't know, Brenda brought up the thing, it's like, I know the answer on how to get students to go into primary care. We've done it. I've done it in 2 other states. I did it in Montana. I did it in Minnesota. It's being done. It's about having longitudinal rotations in the community. It has been done. We did it in Montana with the 3rd and 4th year of the WWAMI program. It was patterned after the Minnesota RPAP and MetroPAP programs. It's exactly why Minnesota has made more primary care physicians than any other medical school in the world, not just the country, the world, family medicine docs. And it is completely possible because what Brenda is talking about, the joy of practice, you need to see that in continuity. We keep bringing up the 4 C's. The most important part is continuity. The difference between training in family medicine residency for physicians and internal medicine residency and peds residency is continuity in the community. 40% of family medicine residency training is continuity in the community. The pediatric folks are just moving into that. They're just realizing that, Brenda, they see that the work you're doing is paying off. They're seeing it. So yes, there are answers. It's not a mystery. I've done it in 2 states already, patterned after Minnesota. It's completely feasible. We need a blue ocean strategy when it comes to primary care medical education. We need to train people in the communities, not just community health centers, in the communities. Longitudinal training in the communities, you will increase primary care, guaranteed. I tried to stop talking, but you kept asking questions that I have answers to. And the PA and NP issue is very different. They're already going in primary care. Our job is to keep them in primary care by fixing the payment and the workload. I promise not to talk anymore.
You don't have to make that promise, Renee, but I think just to step back, I think one of the important tensions that you're calling out is there's recruitment and pipeline challenges and there's retention challenges. And both on their own are necessary but insufficient. And to your other point, I think, which is very salient, different aspects of the primary care workforce have more or less challenges with each of these pieces. And absent having a full spectrum pipeline, recruitment, retention, we won't be successful in addressing many of these. Thanks. David?
Yeah, thanks. So Renee, actually, I thought about it more like those are similar issues that physicians experience too in primary care, burden and payment, right? So I guess I think about it actually, the thing that is different is training. And so I think, and I think Allison mentioned it earlier, the thing that I see within our amazing NPMPA workforce is that first year in which some experience just, it's overwhelming. And so I think if we're going to create a pipeline and retention strategy for our NPMPA workforce is to appropriately make sure that there are training opportunities if someone really feels like that is something that's needed to step into primary care and stay in primary care. And I think there's some really good examples, even within where I work, like of ways that you can do that to help make that successful, that transition successful, and retain people in primary care because they scope down if they don't feel comfortable. So,
David, can I just push you? I believe you're referring to Atrius. I think it would be great for maybe if you want to take a minute or two to talk about some of the strategies that your team has employed when you think about retention and burden.
I think the challenge that many NPs and PAs face is they get into a job, and I appreciate many places say, well, we'll support you. We'll like carve out some time, you'll partner with this physician, but that physician's busy, they don't have time dedicated to do that. And so there's this thought that by osmosis of being close to physicians and other people who are experienced, that they will somehow glean the information they need. And they're super smart, and many of them find that they can figure it out, but it takes a lot of work to get there, right? It's why there's a 3-year residency for physicians or longer. And so I think we've been able to utilize the medicine residency model and dedicate a preceptor who is a teacher for a year that has no other clinical responsibility but to be available to answer questions and go in to see a patient with a new NP or PA to actually be at the bedside and make sure they know this is how you do this specific exam skill, or this is the differential, like what are you thinking about? So I think we've taken an approach that has been, developed over, centuries about how do you train physicians.
Thanks, David. Barbara?
I need to also reflect that internal medicine, we don't have many residents when they're leaving their 3-year of training after internal medicine want to do primary care. And I think Renee raises a really important point that the way many of them, not all, but the way many of them get exposed to primary care is in a model where they're in a more academic medical center clinic, which is very different in many ways than when I am there, at least what I experience in my office, which is off-site. And I think that we need to rethink how are we encouraging the medical schools and the residency training programs, not just in pediatrics and not just in family medicine, but I want to really be sure we include internal medicine. How do we rethink how we train them so that they see the joy of doing primary care, which they may not get in a more academic medical environment. Thank you.
Thanks, Barbara. Allison?
Yeah, and just to reiterate what David had said, I agree with that. And in my practice, we actually came up with a transition to practice, which is like a 2-year program where we really onboard the PAs and NPs and kind of get them like a slow ramp up rather than throw them in with, 20 patients a day. And it's pretty thoughtful, and teaming them with another advanced practice provider along with a supervising physician, but also having lectures and things like that, I think is true. And I definitely agree with Renee that a lot of people do start in primary care and then leave because of money and they go into specialty. as far as PAs go, just because they will either make more money or the administrative burden, all of that is a little lower. So I agree with both of those. I just wanted to reiterate that piece.
Thanks so much, Allison. Appreciate it. Laura, go ahead.
No, again, I think this all then the conversation that we're having about mentoring, onboarding. By the way, a seasoned NP is just very capable of also mentoring, onboarding new grads. But I do think that all comes back to the idea of creating the time and the space and allowing that other provider to be able to offer that time up. And I also think it's interesting where Barbara mentioning to do that outside the context of an academic medical center. Particularly, my practice is tiny independent practice where we consider ourselves fundamentally social workers that prescribe. And I think that it is, having that, being able to do that and having that funding and being able to keep the practice running while we are taking the time to bring up new providers is really important. Then the other thing that I was thinking about, again, the pay, it's interesting when you talk to new grads, particularly MPs who are shocked when they come out of school and they realize what the salaries are. And some of them will say, I've made more money working as a bedside nurse in an academic medical center. So again, when you think about the added level of accountability, responsibility that comes with being a primary care provider, and then looking and turning around and saying, well, I could have just kept my shift work at Mass General and I would have made out better from a financial perspective. I think that's really important to consider as well.
Thanks, Laura. Completely agree. Stephen, go ahead.
Thanks very much. Gosh, the stool, Renee, is very, these three legs are very important, right? Each one. And one that the task force will have to square a circle. So not to mix my geometry here, but current panels, that is the number of patients for whom a given primary care clinician is responsible for, are absolutely untenable. And this is demonstrated just by reality. If you look at from the New England Journal article recently on direct primary care, the reason people are setting up direct care primary care practices is because they want a smaller panel and they still want to be able to make a living. And what they're settling on are panels of about 600 to 800 patients. Because those patients tend to be wealthier, they tend to be healthier, actually. So they're looking for these panel sizes, which we don't have and aren't established. And when they leave, as described in the article, the panels for the rest of us go up and leads that to this negative feedback vicious circle. So I do think we have to not only think about panel size, but also what we, as we mentioned earlier, what we do with our day, but how can we accommodate, how can we recognize that this way of impaneling patients is not working, and that a full-time FTE primary care practice is, to my knowledge, pretty much untenable. See Dr. Critchlow shaking her head. It's not tenable. So we're going to have to resize and recalibrate what we our constraints and our sort of description of the work. How many patients are you working to help? How many days are you in clinic? What are you doing in clinic? What are you not doing in clinic? These are pretty fundamental things that if we don't address, we'll just recapitulate the same current situation that is not working and that people are exiting. So thank you for wrestling with that very fundamental, but I think important set of constraints.
Yeah, thanks, Stephen. Hit the nail on the head. David, go ahead.
Yeah, since we have more time, I'll just throw out a couple more things. Like I think the question, what should we be looking at? What should we be addressing? I appreciate the comment below. What should we do to prompt academic medical centers and medical schools to kind of drive more primary care? How do we create ways that medical schools have primary care pathway programs, maybe like for college, like it's a 7-year program or something that gets people early and puts them on a primary care track? So what are the innovations or levers that we have to get medical schools to truly drive primary care as a priority so they're graduating folks going into primary care? I know, again, I am family medicine, pediatrics, all specialties, APs, NPs that work under me, but if we have to expand one place where we invest in, I do think family medicine is, if you're looking at just the purely the number of people who go into primary care after graduation, as a state, like I think it's a good investment. Second, and then the third point is there are lots of NPs and PAs that are coming into the workforce. So I don't think it's a matter of like increasing the workforce there. It's about getting them there and retaining them there. So again, so the third one is around how to create mentorship and transition to practice programs and think innovatively about how we fund that or incentivize that so that practices get folks to stay within primary care.
Thanks, David. And Renee, I'm not sure if this is what you were planning to discuss, but I know you have previously made a number of comments and proposals around better primary care training. So feel free to make whatever comment you were going to make, but maybe you could also share some thoughts on that.
I was here to back up David and his statement around the how we influence medical schools. I've started in Minnesota a 6-year track that was focused on increasing diversity and also increasing primary care. Because one of the other things a lot of folks don't realize is that when you do make room in medical schools for people who want to go into primary care, you also tend to increase the diversity of your medical student population. And David, 100% right in some of the things that can be done around shortening the length of undergrad and doing a blended BA/MD program is what we did in Minnesota. And 100% agree that it is something that we need to make some tenable efforts on. Mainly, I think where we put our little thumb on the scale for primary care with the medical schools is we need to let them know that it's not an option for them to opt out of primary care. They are basically training subspecialists with our poor people. And they're not providing an avenue to develop primary care for the whole state. So we do need to put our fingers on this, our thumb on the scale with regard to that. And yeah, I just signed on to say I agree with David. Ditto.
Thanks, Renee. In the absence of any hands, maybe I could guide the conversation to the third big bullet around incentivizing the pipeline. And I'll broaden this question not just to be about medical students, but about the primary care workforce in general. Would love to hear feedback and thoughts from this group on how do we, and Renee, maybe this goes to your point around 6-year programs, starting in earlier on. But how do we build the pipeline and incentivize more people to enter the primary care workforce? Stephen, go ahead.
I know I've reached my quota. I'm so sorry, but well, I'm an existence proof that this can work. I was fortunate enough to be accepted in the National Health Service Corps before medical school, and so had my tuition and paid for in full in advance. I'm still paying off loans because it turns out the cost of living in Boston was very expensive, and I had a child. And but nonetheless, that allowed me much more latitude to choose primary care and indeed be responsible for choosing and taking on primary care. And just if people are wondering why this is salient, I did look at the recent tuitions for the medical schools, and they range from a state resident at UMass Chan of $49,000 a year, but all other tuitions are $77,000 or $82,000. Take your pick. Times 4. I mean, that's a recipe for disaster, and it just belies the entire sort of model of how human beings think. To acquire that set of loans is, it's an incredible burden, and it does compel you to do certain things with your career to pay them back. And so I think the state should be very cautious about the repayment side, which is the horse has left the barn by then, and very conscientious about the upfront side, because as folks have mentioned, you get better equity, you get better representation when you pay for people to do what they want to do in primary care. and not leave them to the wolves along the pipeline where they just can't make ends meet without choosing another type of specialty. So thank you.
Thanks, Stephen. And I'll also just add in here, recent federal legislation makes those loans for future medical students even more challenging, and is another layer on top of that complication. Barbara, go ahead.
I was actually going to say that, Ryan, that, the feds now have limited loans to 200,000, which probably pays you for about 1.5 years, 2 years of medical school with expenses. And what my thought is, to just supplement what Stephen has said, is that the state could have a very similar program to the National Health Service Corps, where you enter medical school with free tuition, some support for your living expenses and books. Most medical schools require a car because you have to travel to where you get trained. You can't do it by bus for a lot of them, training programs. And that we create a Massachusetts program modeled on the National Health Service Corps. And, you could even say something like, for every year that you get your tuition paid, you owe 2 years to the state in primary care, but anywhere in the state. And if we really want to, quote, support our federally funded and community health centers, if you do it in a community health center, maybe it's a year for a year, or 1.5 years for a year of payment. Whereas if you do it in a private practice, it's 2 years. I mean, there are ways of modeling it so we still help support our community health centers, but we also support people going into private practices, because all of us know, I bet if I asked every single one of us, that we have friends who live in rather wealthy communities who are not able to find a primary care doctor. So this would encourage people at the gate to stay in Massachusetts and do primary care. Thank you.
Thanks, Barbara. Agree. And I'll just call out, I think many folks on this call are probably familiar, but the Commonwealth does run the Massachusetts Repay program, which addresses parts of this, and Stephen, to your point, is more on the loan repayment side, although I will say NP residencies and fellowships are actually a big component of it as well. It certainly has not addressed each point in the pipeline, but I think the Commonwealth, it's been an admirable investment by our legislative colleagues, and has literally covered thousands of healthcare workers, including physicians, NPs, and PAs, but also many other licensed and unlicensed professionals. So I think I totally hear you, and the importance of continued investment in pipeline strategies. I think, Stephen, your point around there's value in the loan repayment on the back end, sure. There's also potentially more value in upstream investment in getting that commitment and bringing a broader and more diverse pool into training in the first place. Renee, please.
Okay, I'm done apologizing. So one of the things I want to be really clear about is hitting on Barbara's. So I think that increasing primary care across the entire state is critical. And it's not just critical, it is the only lever that we actually have. Because the fact that the state legislature have constituents that can't get primary care is the only way that we're going to get primary care reform to happen. And so training of physicians and NPs and PAs is a critical part. Recruitment early on is very critical. I've spent too much of my life in primary care. One of the things we did, I started a pipeline program called The Ladder, and we started 9 years old. And our whole goal is to expand the pool so that people who are from diverse, underserved populations can understand that they have a potential career in a health career. The increasing the diversity is only going to be possible with things like loan repayment. I mean, loan repayment at the level of college, because One of the papers I wrote, and I'll send it to Kelsey so she can send it on, wrote a paper in JAMA around the way medical school is funded. And diverse URM folks come out of medical school with significantly larger debt burden. And we are at the point, especially with this federal reform, that it would be unlikely that anyone coming out of medical school that has the kind of debt burden we're projecting would even consider primary care. So it is going to have to be critical, and I'll send that along. But I do think it is a very important, and I'm always hitting on the need for us to create a payment reform system that allows more people to go into private practice, because that system will actually make community health centers better too. Because any system that allows someone to go and establish an independent practice in this day and age, that system is going to be better for community health centers. And the GME, Medicaid GME reform that some of the bills are talking about right now, I really think that needs to be a deep part of our conversation. Training the people, using the state Medicaid dollars is going to be one of the important things. And increasing our overall production of primary care doctors means making private practice possible and facilitating longitudinal training in the community. Those are the critical parts. Whatever we can do to fund that, and if it means we need to do it more than just the residency level. It's got to be done at the undergrad level. If undergrad medical school training, like I said, blue ocean strategy, don't fight over the academic med centers. Let's take the work and put it in the community and support it in the community. And those students are more likely to go into primary care. But we got to take care of that loan. It's going to be too much of a burden nowadays.
Thanks, Renee. And correct me if I'm wrong, but I believe the data that you're quoting around the difference between loan burden for URM students and trainees coming out of residency relative to non-URM students, that's years old. That's like data from the 20 teens, and year on year debt burden has increased over that time. And so that difference was bad a decade ago. It's I don't have the data, but presumably worse these days, and will continue to get probably more austere in the coming years, given some of the policy changes we've seen at the federal level.
Yeah, 100%, Ryan. And the URM, the data that we pushed out was that the debt burden is massive compared to, because they don't have any other source.
Yep. Thank you. I think we have time for a couple more comments. David, keep me honest on time here. I think we're.
I'll just jump in and say I really appreciate this conversation, and I think wearing my kind of like public policy government hat, where there are things that we know of that have worked or work, that are, whether that's the longitudinal rotations, Renee, that you're talking about in Minnesota, Montana, whether we're talking about the National Health Service Corps and how they, support and prepay, for this training, whether we're talking about the precept programs that David was talking about as well. Like, if there are other kind of specific ideas, programs, initiatives that you know of, and we'll do our research on this too, that we should be investigating and saying, why can't Massachusetts do that? Why, let's be creative. Like, let's have the state do that, or let's have the state support that in some way. Any ideas you have, please send them along to Kelsey, so we can keep that roster going.
Any other comments as we draw to a close today?
Everyone's just so happy that Secretary Kiame is being sworn in right now.
We can't beat that show, Renee, but we got to do our best. Brenda, thank you.
I would just I think it's sort of been said, but reiterate that if we were to create some great opportunities in Massachusetts, we can consider then it wouldn't be just retention of people who train here, but it would be a desirable place to come work. And so if we, not just for the Cape and the Berkshires, et cetera, but for a really great opportunity to practice medicine. We're like a primary care desert.
Yeah, despite being the single best healthcare state in the country and the best per capita ratio of providers, our primary care ratio is certainly not.
We're number 45, right?
That sounds right. All right. Any other last comments before we close today?
Ryan, I just had one slide to share about some recent research that the HPC put out. But before I turn to that, I just also wanted to reflect, a number of comments made around wanting to have maybe the bigger picture conversation of like, what is the vision that we're trying to work towards? What is the vision of the future of primary care and patient experience and clinician experience and worker experience that we're, philosophically all trying to work towards in this primary care task force? I think you all know that I've been trying to keep us focused on some of these deliverables that the legislature has asked us, but I recognize that there is this bigger conversation, and I think a valuable one. And so our next full primary care task force meeting is in September, and we're asking that we do that in person. And I think that would be a great conversation to have in person with a full task force and to get input on that. And Stephen and others have raised this, and we don't have to start from scratch, right? And so we can bring some of those concepts and principles to that conversation. But before we close out today, I just wanted to highlight for this group that the HPC just yesterday released a small data points, what we call data points. It's kind of like our online research blog. And we use this as an opportunity to kind of take a very specific and focused data analysis and wrap some commentary around it and put it out publicly. So yesterday we released an issue on our website called The Primary Care Spending Gap, Paying Less for What Matters Most, to really try to underscore what we see in the payment in terms of undervaluing the time and effort of cognitive care and primary care as compared to procedures. And this has been a payment dynamic that maybe begins with Medicare, but has translated it out into the commercial market as well. And so what we did for this analysis is we created a basket of specialty procedures, which we particularly identified as being both kind of very common, but also very low acuity, that do not need necessarily specialized training or equipment. We're not talking about hospital care. We're not talking about like hip and knee replacements. And created and adjusted the payment to a 30-minute amount of work time, and created the specialty basket of these procedures, adjusted to 30 minutes, and then compared that to the payment for an E&M visit. And what we found, not surprisingly, is that there is a significant ratio and difference in terms of what payers pay. On the far left, just to use United as an example, you can see in kind of the orange that the payment for the E&M visit on average $140, a payment for an equivalent 30 minutes of work in that very common specialty procedure bucket over $660 with a ratio of 4.5. So this was just a claims analysis that we thought was interesting and useful to continue to make the point that we need to invest in primary care. And so encourage you all and everyone listening to check that out on our website. And if people have thoughts and questions about further work we can do in this field, would very much welcome that. We plan to do something similarly around a behavioral health, visit compared to the specialty procedure basket as well, and probably suspect we'll see a similar story. Thank you.
Thanks, David. Appreciate it. If there's nothing else, I just want to thank everybody for your time today. Thank you to those who joined us remotely. A lot more discussion to come in the coming months, and a very large mandate in front of us. But thank you all for